Hi class, this is Dr. Shahada. In this video, I will be going over Chapter 4 titled Health Services Professionals. So right now, I'm actually in the module that covers Chapter 4. As you can see here is the PowerPoint presentation. Medical Technology is Chapter 5. Okay, so this video covers Chapter 4, Health Service Professionals. Here's the PowerPoint presentation. I will be going through the information provided on some information from the chapter section for Chapter 4, as well as jumping to the slides as I've done with the previous chapter videos or lectures. All right, and here is the file with the terms and definitions from the chapter. So let's get started. I'm actually going to begin with the slides. So I'm going to jump to the PowerPoint presentation for Chapter 4. All right, so here we are. Now, the U.S. healthcare system is the largest employer in the nation. It constitutes more than 3% of the total labor force. Now, between the years of 2008 and 2018, the projected growth of healthcare practitioners and technical occupations is estimated to be about 21.4%. And the projected growth for healthcare support occupations is about 28.8%. So when we're talking about health service professionals, we are speaking about physicians, nurses, pharmacists, optometrists, psychologists, non-physician practitioners, health service administrators, allied health professionals, such as therapists, social workers, health educators, laboratory and radiology technicians. Now, the first one we begin addressing here are physicians, and I'm not going to go into deep detail or in covering each health service professional that was just listed in the previous slide. I feel like a lot of it is self-explanatory. I do provide a lot of detail in my slides, as well as you have your textbook. But regarding physicians, the major role of physicians are to diagnose diseases and treat patients. So physicians must be licensed to practice. The licensure requirements include graduation from an accredited medical school that awards a Doctor of Medicine or a Doctor of Osteopathic Medicine degree. They do need to complete it successfully, as well as a licensing examination, which is the National Board of Medical Examiners or the National Board of Osteopathic Medical Examiners, and completion of a supervised internship or residency program. Physicians practice in a variety of settings and arrangements. So some physicians work in hospitals as medical residents or hospital staff. Others work in the public sector, such as the federal government, public health clinics, community and migrant health centers, schools, and prisons. Most physicians practice in offices either as a solo or group practitioner. An increasing number of physicians are partnering or salaried employees or becoming salaried employees under contractual arrangements, working in a spectrum of outpatient settings, including group practices, surgery centers, diagnostic imaging centers, urgent care centers, and managed care organizations, such as HMOs, health maintenance organizations. Okay? And the difference between an MD and a DO. Now, I do want to make sure that everyone understands that when we're talking about allopathic medicine or MD, the views are more on medical treatment as an active intervention to produce a counteracting reaction in an attempt to neutralize the effects of disease. Okay? When we're looking at osteopathic medicine, their perspective emphasizes the musculoskeletal system of the body, such as the correction of joints or tissues. Now, over the years, in the last 2 decades or so, they've become, you could have a DO or an MD and it should be looked at as the same. The platforms of each, manner of, educational curriculum have really become, have merged, I guess is the best way to put it. So in the MD programs, a lot of allopathic thinking or regarding alternative medicine or has also been included there, that there has been this growth of merging both areas, okay? And MDs are being taught to focus more on preventative medicine, as DOs are being, encouraged to provide medical treatment, medications when needed. So there is that merge going on, but the primary platforms of what differentiates both types of study in medicine, are still evident. So in this slide, as you can see, we're looking at the differences here. So an MD is trained in allopathic medicine. About 42% work in primary care. You do find more specialists with MDs. The use of preventative medicine along with allopathic treatments. So as you can see, preventative medicine has been encouraged in allopathic medicine, okay? With DOs, they practice osteopathic medicine, a lot of stress on preventative medicine. They account for about 5% of all active physicians. More than half of all DOs are primary care physicians, and they definitely take a holistic approach to patient care, okay? Now, regarding PCPs or primary care physicians, also known as generalists. So they provide preventative services. They treat frequently occurring and less severe problems. Now, I do want to point out they are also tend to be the gatekeepers. Specifically, we see this in HMOs, also in healthcare systems in Europe. They are viewed as the gatekeepers, not just with HMOs or just with insurance, regarding the healthcare system as a whole. You generally go first to the PCP before jumping to a specialist. I know here in the US, depending on the type of insurance you have, some people have open access or PPOs, and they'll just jump to a specialist rather than going through the PCP first. But it is strongly recommended to always go to your PCP first before seeking out specialist care. Now, specialists seek certification in an area of medical specialization, requires additional years of advanced residency training, and requires several years of practice in the specialty. Now, what are some of the differences between primary care and specialty care? Well, primary care may be distinguished from specialty care by the time, focus, and scope of the services provided to the patients. Primary care is the first contact care or the portal to the healthcare system, whereas specialty care, if needed, generally follows primary care. So primary care focuses on the person as a whole, whereas specialty care focuses on disease or organ systems. Primary care is comprehensive in scope and includes health promotion, disease prevention, health maintenance, counseling, patient education, diagnosis, and treatment of acute chronic illnesses. Specialists are more narrowly focused. Okay? And now this slide pretty much covers what I just touched on. So I just pretty much covered this, but primary care, again, first contact of care. They serve as gatekeepers, serve as patient advisors and advocates. They focus on person as a whole. They're looking at more of long-term, care, and there's significant training in ambulatory care settings. Now, specialty care generally follows primary care, requires a referral from a PCP, when, with most HMOs, most insurance plans, centers on particular diseases or organ systems. They're associated more with secondary and tertiary care. and there's significant training in inpatient hospitals. Now, in the next couple of slides, we're going to be touching the slides. They cover the topic of hospitalists, which are physicians that usually have no relationship with the patient prior to their hospital stay. I'm not going to be going over the slides because I do believe they're pretty much self-explanatory. Make sure to read through them and make sure to read that section in your textbook. I am going to jump to the maldistribution, okay, which is focusing on the surplus or shortage of a type of physician that's needed. So let me jump to that slide. So maldistribution refers to either a surplus or shortage of the type of physician needed to maintain the health status of a given population at an optimum level. So a surplus of physicians increase medical expenditures. Physicians concentrate in metropolitan and suburban areas than in rural and in inner city areas. So rural areas lack the economic capacity to support additional physicians. So physicians are more likely to concentrate in metropolitan areas because the former generally offer greater perspectives for income, professional interaction, access to modern facilities and technology, continuing education and growth, high standards of living, and social amenities such as cultural diversity, recreational activities, and a quality of education for their children. Okay, so that's really that pull to stay in metropolitan and suburban areas in comparison to rural. The basic physician labor force problem in the U.S. is that while the supply of physicians is largely determined by population need through government finance or subsidized medical education, medical services are delivered in a market that links services to the ability to pay, whether through insurance or out of pocket. So the need-based model assumes an even distribution of physicians in the projection of labor force requirements and planning of physician training. But the market-based model is driven by supply and demand factors. So the inconsistency between the two models largely contributes to provider surplus in certain areas and shortages in other areas. So there has been a considerable imbalance which exists between primary care and specialty care. About 42% of physicians work in primary care, remaining 58% are specialists. So the major driving force behind specialists is the development of medical technology. The rapid advance of medical technology expands the demand for specialty services and provides an impetus for specialty development. So higher reimbursement for specialists relative to primary care physicians also contributes to the current imbalance. Specialists not only earn higher incomes, but they also have more predictable work hours and enjoy higher prestige both among their colleagues and from the public at large. Again, I just touched on that. And then the following slide is the shortage of primary care physicians. It's just a short video that touches on the topic. So the next question comes to mind. What are some possible ways we can increase PCPs in the U.S.? So there's been a number of attempts that have been made to resolve this maldistribution problem, to alleviate the shortage of physicians. For example, new medical schools were instituted in the underserved areas, inner city and rural. Financial support for family medicine programs was increased after research established its efficacy relative to more highly specialized areas of medical practice. Nurses in expanded roles, nurse practitioners, emerged as a viable option to remedy the many facets of the health labor force problem. A combination of various policy options has also been initiated. So these options include the regulation of healthcare professions, change in reimbursement policies, and targeting programs for underserved areas. Federal programs addressing specialty maldistribution include the National Health Service Corps and migrant and community health programs. Support of primary care physician training programs, and support of area health education centers. So to achieve a better balance in the proportion of PCPs and specialists, continual efforts are needed to improve the specialty distribution of physician labor forces. Medical schools need to develop students' competencies in skills, values, and attitudes relevant to the practice of primary care. Their curricula can be oriented toward issues of special concern to generalists, such as outpatient experience, public health concepts, disease prevention, and cultural, ethnic, and population-specific knowledge. Medical programs can provide students with opportunities to work with the poor, minorities, and the uninsured to practice in rural or underserved areas. The means of financing medical training and physician services can be improved. So the system of graduate medical education payments through Medicare contributes to specialty-oriented training and creates disincentives for primary care training. So a possible solution is to encourage and provide priority funding for primary care residency slots and primary care related research. Hospitals whose graduates actually go into primary care in underserved areas should be rewarded. Reimbursement to providers and patients should emphasize preventative primary care services. They should also stress the attributes of primary care. So some physicians tend to practice in affluent urban areas. It is necessary to differentially reward providers who practice in less desirable areas. That is very important. So as you can see from some of the things I just listed, they're included here. 17 new medical schools committed to only PCP training. Several federal programs have been successful in increasing the supply of primary care in rural areas. The whole idea is to make the area of primary care more attractive, because in order also for us to improve our health outcomes here in the U.S., our focus needs to be in preventative care, and that involves having a higher percentage of primary care physicians. And that is exactly what's going on in European countries who have been rated with higher healthcare systems, and they also have higher health outcomes in comparison to us here in the U.S. As you can see, when there's a strong primary care network, it can reduce costs. So each 1% increase in PCPs, we have 503 fewer hospital admissions, almost 3,000 fewer emergency room visits, and 512 fewer surgeries annually. Now, I do want to touch on one thing really quick here. There is, if you're interested in reading more about this, the effects of having more PCPs and how it can really impact healthcare costs overall, there is a model that was created by a man named Dr. Brenner. A very interesting story. And he has this model called the hotspot model. And, what happens is a lot of our healthcare costs go up with the overutilization of the ER. So his focus was looking for those patients that are usually in lower income areas that only use the ER when they need to, rather than regularly going to a primary care physician. And he went out with a team, himself, nurse practitioners. There were like a group of nurses and different healthcare providers. And they went and actually provided healthcare services to these patients in their home. And it was amazing to see when they were checked regularly how it obviously reduced their ER visits and reduced healthcare costs for the hospitals in that region significantly. There was a couple of other articles. He also did a TED Talk that touched on this hotspot model and how effective it is. And of course, you have people that don't agree, but it's very interesting because it really focuses on this topic, the increase in the primary care network, which will ultimately reduce costs. Again, targeting programs for underserved areas, which I briefly touched on, is also very important. All right. So the next topic I want to briefly touch on is health service administrators. As I said, the slides are very self-explanatory along with the textbook. If you have any questions, be sure to let me know. I am going to jump down to the slide for health service administrators. All right, so health service administrators are employed at the top, middle, and entry levels of various types of organizations that deliver health services. Top-level administrators provide leadership and strategic direction. They work closely with governing boards and are responsible for an organization's long-term success. They are responsible for operational, clinical, and financial outcomes of the entire organization. Now, middle-level administrators may have leadership roles for major service centers, such as outpatient, surgical services, or nursing services, or they may be departmental managers in charge of single departments, such as diagnostics, dietary rehabilitation, social services, environmental services, or medical records. Their jobs involve major planning and coordinating functions, organizing human and physical resources, directing and supervising operational and financial controls, and decision-making. So they often have a direct responsibility for implementing changes, creating efficiencies, and developing new procedures with respect to the changes in the healthcare delivery system. And last, we're going to speak about entry-level administrators. So they may function as assistants to mid-level managers. They may supervise a small number of operatives. Their main function may be to oversee and assist with operations critical to the efficient operation of a departmental unit. All right, and we are almost done. So here is the ACA takeaway. Now, in each chapter PowerPoint presentation, I always have a section with the Affordable Care Act takeaway from the chapter. Always make sure to review it. In this case, the ACA takeaway from this chapter was really looking at how to alleviate the shortage of primary care providers. So the ACA invests $230 million to increase the number of medical residents, nurse practitioners, and physician assistants, or PAs, trained in primary care. So as of January 1st, 2013, ACA began to require health systems and physician groups to form accountable care organizations, or ACOs, that will work as teams to provide coordinated medical care for eligible Medicare Part D recipients. All right, so that pretty much covers it for Chapter 4, what I plan to review. I do want to quickly jump back to some information from the chapter section and from this week's module, but I'm pretty sure I covered everything in there. So let me do that right now. All right, so here we are. Now, this little section here talks about the differences between an MD and a DO, which we did address, but be sure to go through what I have here. And we did touch on the differences between primary care versus specialty care. And then last, for Chapter 4, we have the global trends in healthcare professionals, which I did not touch on. So really quick, just keep these in mind. Many countries face a healthcare workforce shortage, meaning that each country has less than 23 health workers per 10,000 people, which is really, when you give yourself a minute to process that, it's pretty extreme, the shortage they have. In Europe and in the US, the numbers of doctors is insufficient to accommodate to the growing need of the aging population. And you will find this issue to be in many countries. Next, a growing public health concern is the migration of health professionals from developing countries to the US, UK, Canada, and Australia. And patients from more developed countries often travel to less developed countries for cheaper and more accessible care, which I did touch on earlier in this chapter. Now, that covers it for chapter 4. If you have any questions at all, do not hesitate to email me. Make sure to read the chapter, go over the PowerPoint presentation, make your own notes, and if you have any questions, let me know. Take care, everyone. Bye.